Good afternoon and welcome. My name is Edith Lee and I'm the Vice President of U.S. Programs for Americares. Thank you for joining us today to learn more about the Roadmap to Health Equity initiative, led in collaboration between Americares, Loyola University, the National Association of Free and Charitable Clinics, and free and charitable clinic stakeholders across the country. Americares is a health-focused relief and development organization that saves lives and improves health for people affected by poverty and disaster. Each year, Americares reaches more than 90 countries, including the United States, with life-changing health programs, medicine, and medical supplies. Americares' U.S. program is the leading nonprofit provider for medical aid to the U.S. healthcare safety net. We support a network of 1,000 clinics and health centers serving more than 7 million patients in need. Our U.S. program helps partner clinics increase capacity, provide comprehensive care, improve health outcomes, and reduce costs for patients. The topic of health and all the factors that contribute to health outcomes has evolved over the years. We now know that roughly 10% of our health is determined by accessing health care, 30% by genetics, and 60% by social and environmental factors and the behaviors that result from those social and environmental factors. Recognizing that the choices we make are shaped by the choices we have. Today, I have the privilege of introducing two national experts on the topic of social determinants of health. Together, they co-authored the book, How Neighborhoods Make Us Sick, Restoring Health and Wellness to Our Communities. Brianna Lathrop is the Chief Operating Officer and Nurse Practitioner at Good Samaritan Health Center in Atlanta, Georgia. She has spent over a decade providing health care to individuals and families who lack health insurance. She earned her Doctor of Nursing Practice from Georgia Southern University and Master of Nursing and Master of Public Health from Emory University. She is passionate about health equity and addressing social determinants of health. Brianna is a Robert Wood Johnson Foundation Culture of Health leader. Veronica Squires is Chief Administrative Officer at Good Samaritan Health Center in Atlanta, where she leads fundraising strategy and development efforts. She previously served as Director of Corporate Development for Boys and Girls Clubs of Metro Atlanta and is the Georgia Director of Ministry Partnerships for InterVarsity Christian Fellowship. She is a certified Christian Community Development Association practitioner and serves on the advisory board for the Georgia Charitable Care Network. Our Americares team member, Christina Newport, will also present today about the Roadmap to Health Equity. She serves as Director, Quality Improvement and Behavioral Health of the U.S. program at Americares. Christina has over 14 years' experience in public health with a background in quality improvement. She currently holds her Patient-Centered Medical Home Certified Content Expert certification with the National Committee of Quality Assurance. As a reminder, this presentation is being broadcast across the country via Livestream. We would ask that we be mindful of the cameras in the back, and if you do have to get up and leave, that you use this door to the front. We will have a Q&A period at the end of the presentation, and then refreshments and an opportunity to visit with our presenters in the lobby immediately following. Please give a warm welcome to our guests.
Thank you so much. On the side. Thank you so much, and good afternoon. We're really honored to be here. And before we start, just wanted to say what an honor and a pleasure it is to be here with you all. And really, I think the applause should be turned around to you because we so admire the work that you do. And I think you'll hear in our presentation that so many of the issues that we will raise in terms of community health are very much being addressed on the front lines by Americares and the good work that you're doing. So thank you all for that. Really appreciate it. So to kick us off, let's see if I can get these to work. Yes, it does. Technology is on our side today. So I'm Veronica Squires. This is Brianna Lathrop, and I'm going to kick us off just by sharing a little bit about my personal story, and Brianna will do the same. And then we'll kind of share the stage here and talk through a few things related to our experience and what makes communities sick, but then also give the good news as to some ideas, things that can make communities well again. So it's really interesting to even be here speaking and being thought of as a national expert. Thank you, that's kind. Because in many ways, my story starts from a place of failing. Taking it back a number of years, I won't say how many, to college, when I was an undergraduate student at Emory University, I was involved in a group called InterVarsity Christian Fellowship, which really focuses on issues of inequity, social justice, racial reconciliation. And as being part of this group, I was really inspired as I graduated from school and married my husband to intentionally move into a low-income community in Southwest Atlanta as a way of doing intentional community redevelopment work, and really with the vision of seeing a community restored by bringing leadership, resources, and ideas back into a community that had just experienced decades of a drain of resources out of the neighborhood. So we were excited, we were young, we were motivated, we were going to do this bold thing, and so, probably pretty naive too. So we moved in with all these great ideas. We were certified in Christian community redevelopment. We'd read the books. We talked with the experts. And what we found really quickly upon moving into this very low-income neighborhood in a food desert, high crime, gang activity, and kind of what you might imagine in a low-income community in Southwest Atlanta, what we found really quickly was that our training and our tools were not enough. So a few examples. We started running tutoring programs out of our house on the weekends. And what we quickly found was that after school and weekend tutoring was not enough to make up for huge gaps in resources in the local school system, specifically the local elementary school where we were also volunteers. Another example, we quickly found that helping young men with a record apply to jobs, rewrite their cover letters, dress professionally, and learn how to give a firm handshake while looking someone in the eye was not enough to make up for a bias in the hiring process against people who had previously spent time in jail. And so about 2 years in, we found ourselves very discouraged and frustrated that all of these efforts were just simply not moving the needle for our neighbors and these families that we grew really quickly to love. And then beyond that, what was maybe even more surprising was that we found that our own family started to exhibit signs of sickness related to chronic stress, both physical ailments as well as mental health issues, and that the environment and the conditions of the neighborhood were also taking a toll on our own family. And so it was around this time, a few years into this life experiment, if you will, that we were discouraged. We were wondering, what in the world, have we done? What are we doing here? That we started asking questions as to what are the conditions in these communities? What's happening here? And it was about this time, actually, that I met Brianna and started working at the Good Samaritan Health Center, that it was like a light bulb came off, that so many of the issues that I saw my neighbors struggle with daily were very much being addressed by a lot of the work Good Samaritan's doing. Certainly not all of the issues, but many of them. And then through knowing Brianna, I got introduced to all this fascinating data around life expectancy gaps and social determinants of health. And it really started to help make sense as to why in these communities, which we talk a little bit in the book about how this idea of chronic stress is almost like a leaking faucet. It's not necessarily always one big, huge traumatic event, but it's just the chronic dripping of stress that research is now showing that just chronic stress itself looks like the same impact in the brain as a major traumatic event. So this idea that as it just drips and drips and drips on these families and communities that, drips, imagine dripping on a sidewalk. If it just drips for a day, you're not going to notice any difference to the sidewalk. If it drips for a week, maybe you start to see a little bit of a discoloration a month, the same. But if it drips for years and years and years and generations, it can actually erode the concrete. And that is very much an analogy to what's happening inside the bodies, the families in these communities where chronic stress and trauma are so prevalent. So it was very much in meeting Brianna and coming to the Good Samaritan Health Center that started to make sense of what was happening, not only for my family and my neighbors, but starting to see at a larger level what's happening in many of these communities across the country. So with that, I'll turn it over to Brianna.
My journey into healthcare actually started at a free clinic, like many that Americares supports. I was a high schooler in Iowa, and a free clinic started in the basement of our church one weeknight per week, and I would go and I would clean out the supply closet and I would check patients in, and to me those providers were superheroes. They were folks that had resources to be able to actually provide a service to people in need, and I said, that's what I want to do with my life. So with the mentoring of a wonderful nurse practitioner at that clinic, I went on to school and started working in clinics as a student, and really quickly realized the limitations that were on me as a provider because of how the healthcare system in the U.S. works. So after graduation, I went on, and during my time at Emory also pursued my master's in public health and health policy, thinking if I can just understand and change the healthcare system, then I can provide better, higher quality care for everyone. There has to be a way. And so I got my MPH and I got my degree as a nurse practitioner, and I went to practice in a full-time clinic with only 2 exam rooms, serving exclusively people without insurance. And while I loved what I was doing and connecting with my patients, I found myself overwhelmed by how much I didn't know, that none of these experience or degrees had prepared me for the realities that my patients were facing, that I could know everything there was to know about asthma management, but prescribing an inhaler and sending someone back to a mold and toxic environment as a renter with no ability or power to pursue change in their environment meant that they were still just as sick. And when I prescribed insulin and didn't ask someone if they had consistent refrigeration, then I'd missed the most important thing impacting their health at that time. So I was discouraged, overwhelmed, and thinking, well, what did I miss? What tools am I lacking? And so I did what I do best and went back to school. But this time I specifically focused on understanding what is health equity, what are the social determinants of health, and kind of unlearning what I had learned wrong and rebuilding this idea around what are the right tools and the right messaging that I need to know to bring to my patients, but also that we need to know as a society if we care about making health equity a reality. So like Veronica, I very much see my story as one of failing forward, one of figuring out what I didn't know, and still seeing myself on this journey to figure out how we do this better. And I'm excited in that I think that there are very real and tangible ways that everyone, regardless of where you see yourself and where you work currently, can make an impact on our ability to create healthy neighborhoods. So let's talk about what is health equity, what are social determinants of health. We're here because we care about health. We care about the health of our communities and our nation and our world. And so for many of us, the first step is to say, well, what's happening in healthcare? Are people getting care? Can they access it? And this is important, but we have to keep in mind that medical care alone prevents only about 10 to 15% of premature death in the U.S. So there's a lot left on that pie graph. So we take a step further outward on this target, or further upstream, and we talk about health behavior. These questions: do you smoke? Do you drink? Do you exercise? What food are you eating? And these factors are also extremely important. I'll also note, though, that even health behavior is strongly influenced by our environment and our access. But even if we say, for argument's sake, that health behavior is totally within our control, it still only explains about 30 to 40% of additional premature death in the U.S. So for those of you doing the math, we're only at about 50% of premature death that we're impacting when we talk about medical care and health behavior. Where is the rest? And this is where we start to talk about social determinants of health. When we think about education and housing and employment, do people have safe places to live? Do they develop community and social cohesion that's protective of health? Do their jobs offer a chance of social mobility, a chance of control, or is it high demand with low levels of control that are bad for health? Is housing outside? Is it in a home? Or is it in the cycle of eviction and wondering where is the next place? Where will I live tomorrow? But finally, we can't stop there. As we talk about the disparities that exist in all of the conversations about the way in which oppression, racism, poverty, classism, and socioeconomic status have impacted all of these other disparities that we see. And we have to think about the way in which our nation has been built on systems of oppression and racism, and that part of building healthy communities is undoing this. So broadly defined, using the World Health Organization's definitions, social determinants of health are the conditions in which people are born, grow, work, live, play, age, learn, that affect the health and quality of life, both how long you live and the quality of it. And they're impacted by the distribution of money, power, and resources. And so when we want to address social determinants of health, we have to ask ourselves, where is the power? Who has the money, and how are the resources distributed? Right now, we're not living in an environment of health equity. This map may be familiar to some of you. It's funded through the Robert Wood Johnson Foundation, but it shows the life expectancy gaps in different urban areas throughout the U.S. This map shows the zip code of the lowest life expectancy compared to the zip code with the highest life expectancy. And you can see that this is a national problem, that there's no urban area analyzed where there isn't a life expectancy gap, meaning that simply the zip code here is the factor. We're not talking about anything else. It's leading many researchers to start suggesting that perhaps zip code matters more than our genetic code in predicting our health and life expectancies. Now, this looks grave, but the neighborhood statistics are actually even worse. So today we're in Sanford, so I pulled statistics here looking at actual census tract data, which narrows us down even further from zip codes to actual communities. We see here in tract 204 a life expectancy of 88.4, pretty good. About 15 minutes away in census tract 220, we see a life expectancy of 77.7 years, a gap of nearly 11 years in this city. Veronica and I flew in this morning from Atlanta. We work directly across the street from the neighborhood that is Census Tract 23. This is where a lot of our patients live. Their life expectancy in that neighborhood is 63.6 years. If you take what's about a 20-minute, depending on traffic, drive up into the more northern part of the city and the suburbs, here life expectancy is 87. We're looking at a 23.6 life expectancy gap. So this sounds dismal and a little disheartening, and it should. We should care that in a country with resources, we have this type of discrepancy by zip code alone. But as a healthcare provider, I also see some hope here, because if someone comes and sees me for a health problem, I can't change their genetic code. I can't change their risk factors. I don't know about the cancer that they may have inherited from a family member. But zip code, disparities in zip code, is something we, as a collective community here in the U.S., have the power to change. And so today we're going to talk about what does that look like? Where do we start to make a difference? I do want to just point out, to go back to one of Veronica's points, on why it is that we see this kind of life expectancy gap. Especially as someone that comes from the more medical world, it helps me conceptualize what we're talking about here. How do social determinants of health actually impact our body? And I think it seems intuitive to say that, maybe someone experiencing abject poverty or homelessness would be more likely to get sick. But it's actually more problematic than that. That we see that people living in environments, whether it's poverty, whether it's constant cycles of unemployment and new work and unemployment and new work, concerns about where their kids will go to school, will food stamps last till the end of the month, that results in chronic stress. Now, our bodies were built to handle short-term stress. We can recover, we can run away when being chased by a dog. But over time, those adaptive mechanisms that are good, the ability for our heart to race, our blood pressure to go up, become maladaptive. And then we see things like chronic hypertension. Over additional time, we see that there's actually permanent changes to the neuro and endocrine systems. This not only causes increased rates of diseases like diabetes or preterm birth, but then can be inherited, passed down from one generation to another. And finally, we see that chronic stress has an impact on premature aging. Now that we have research around telomeres and some of the piloting work of Nobel Prize winner Dr. Geronimos, we can see that we can predict life expectancy based on how quickly people's protective end caps of their chromosomes are wearing down. Folks experiencing racism, folks living in poverty, have shorter telomeres and therefore lower life expectancies. So all this is to say that there is a direct correlation between these social determinants and the quality and lifespan of our communities. So what does that mean for us if we want to do better? And this is where we talk about health equity. We use this diagram from our book because I think it helps us say, what kind of solutions are we looking for? And as you can see in this picture, everyone involved in this picture is hoping to reach good health. That's the apple on the tree. Equality-based solutions come in and say, okay, great, we're just going to send something out and we're going to say, let's have a clinic within a 10-mile radius of everyone, or let's put a grocery store with fresh produce on every corner. And certainly these are good initiatives, and it helps one person in that little diagram reach that apple. But two people are really no closer from good health than they were before the box came along, because they're simply not able to obtain it. Nothing they can do, no amount of stretching will get them there. Equity says when we want to fix health disparities, we come in and we say, what does this individual, what does this community need to be healthy? And we match the intervention to the problem. It means we have to understand that not everybody is starting at the same place, that folks that have experienced racism or grown up in poverty or had adverse childhood experiences or live in neighborhoods with no grocery stores, that this community, this individual needs something different than someone a zip code away to be healthy. So how do we do this? This is a diagram of a common public health analogy of moving upstream. The story goes that there's some public health folks or providers having a picnic, and they notice people are drowning in the pond next to them. So they, being good people, say, let's jump in and pull the drowning people out of the water. And after they've saved about 4 or 5 drowning people, one of their colleagues says, well, I'm going to go swim upstream and see what's happening up there, because this seems ridiculous that all these people are drowning. So he's swimming upstream and trying to get people before they get to the deep part, see if he can get them out sooner. And finally, someone jumps out of the river altogether and says, I'm going to go find out what is pushing people in. And all of us are doing work along this continuum, and all of it is important. I always think of a lot of my work as pulling out drowning people, and that's good and important work. But we are also community members, and we are citizens, and we are voters, and we live, and we play, and we worship, and we do all the things we do with our lives in a space of community. That means that each of us also has power to impact these upstream factors. And the first step is simply that awareness, to start saying for ourselves, for our organizations, for our families, for our spaces of influence, what impact do we have? 3 critical questions that I'd like to offer as kind of a starting place into thinking about this is, how are we increasing our understanding of inequity and the impact of social determinants in our communities? Start with who you know best and where you live. And then moving on to say, how are we, or how am I personally recognizing the ways in which I might be contributing to systems of inequity, often unknowingly? And finally, asking ourselves, what power, what influence do we have to change systems and the social norms that create these, that allow health inequities to persist? And how do we change that and make health equity a reality? So we'd like to suggest a few practical ways to start addressing, for moving kind of from immediate to moving upstream within this context. And first is simply for those of us in clinical environments and supporting clinical environments, is to start learning, what do the folks that we're serving need in terms of social supports? When we screen for social determinants of health, it's like doing universal depression screening. We learn what we didn't know. People know what they need to be healthy, and communities are best equipped to tell us what they need. So let's make sure we're asking. Using some type of screening tool as patients access resources to decipher what are the needs of this community. At an immediate level, it helps us be able to link individuals to other service providers and agencies to get immediate assistance. But it also informs our ongoing program development as we write grants, as we structure new programming, to make sure that we're targeting what people need. Then, as we aggregate this data on a larger level, it enables us to inform larger systems. And this is what we'll hear more about when we talk about the roadmap to health equity, is this idea that if we start pooling this data from many communities, then we can really say, where are disparities showing up? How do we then focus our resources, development, and program initiatives around these areas? But I always caution at this point in our talk that simply saying meeting the social needs of individuals is not the same as addressing social determinants of health. One of my favorite quotes here from a health affairs blog suggests that when we look at individual level interventions and we label that as saying, oh, we fixed it, we've addressed these social needs, we've fixed social determinants of health, what we've failed to do is we've failed to implement the long-term fixes that are required to really create equity in the U.S. So we have to move upstream. And this is where we have to do some personal introspection, as well as introspection within our communities and organizations, about what are those upstream factors around oppression and racism, socioeconomic status, and poverty that influence our decision-making in our day-to-day interactions with patients or our policies at an organization or larger level. And we're gonna give a couple examples of how we unpack this in our lives and in our communities. And I'll start first with talking a little bit about the issue of racism and implicit bias, and then turn over to Veronica to talk about our narratives around poverty. You'll see that I use this picture of flowers. The brilliant Dr. Kamara Jones, who's an international expert on racism as a social determinant of health, uses this analogy to help us unpack why we have to have these conversations. She tells the story of a gardener who has 2 window boxes and is planting red flowers and pink flowers. And this gardener, for whatever reason, has decided that she prefers pink flowers. So she plants both, and she gives both some soil and some water, but she tends to those pink flowers with everything, right? They get the best and the first supply of the fertilizer and the best sunlight. And with time, the pink flowers grow and flourish, and the red flowers grow too, but they're not flourishing to the degree that the pink ones are. And the gardener says to herself, well, see, I was right to prefer pink flowers. Now that gardener moves on and another gardener comes in, and that gardener looks at the situation, and that gardener really doesn't have a preference between red or pink flowers, but starts treating them the same. And over time, the pink flowers continue to blossom and just do wonderfully, and the red flowers do a little better, but we're still missing the problem, right? Is that there were years and years and years in which the red flowers were deprived of resources. If we are going to fix the situation and allow both flowers to grow equally, we have to get to the roots. We have to look at the soil, and we have to talk about undoing damage that was done. And this starts by acknowledging that all of us have narratives that we bring with us to our work and the way we interact with this world. And the term implicit bias is probably familiar to many of you, but it's simply those beliefs and stereotypes we hold that we're not even aware of because of who we are and where we were raised in our communities. There's testing, you can test yourself, but essentially what we've learned is it's not necessarily a choice to hold certain views, but if we're not aware of it in ourselves and the impact it can have, we risk doing more damage. So it starts with simply being willing to say, what is my narrative and where does my narrative need to be challenged? And we suggest even just having conversations about your own story and that in relation to your community is saying, in which roles am I privileged? Maybe it's by race or by gender or education or socioeconomic status. And in which areas might I have experienced oppression, being systematically marginalized because of the way I look or who I am? And moving from conversations that focus on shaming and blaming and generalizations to ones about inclusion, saying that diversity doesn't fix the problem, but inclusion, making spaces safe for everyone to contribute and flourish, does. Being vulnerable about where we were wrong and where our narratives were false or even harmful, and moving towards intersectionality, knowing that all of us are multiple identities and bring that to the work that we do. I'm going to turn it over to Veronica to talk about changing our narrative around poverty.
Thanks, Brianna. I should say, as we start to get into this, Brianna and I share a lot of this information very much from a place of learning it first. So not from a, this is how you ought to think, but more from, again, failing forward of these are the things we've learned along the way as practitioners in the field that have really corrected our own narratives about how we think about things. So one is going from a place of thinking of poverty as a condition to more of thinking of poverty, as I mentioned at the very beginning, as a trauma. And if we shift our thinking in that way, how might that impact our treatment plans or interventions that we think about for patients? Another one that particularly was relevant for me growing up in more of a kind of conservative Christian environment was thinking about poverty as a consequence, particularly of maybe bad behavior, to thinking about poverty as more of a societal problem, that the fact that there are people living and sleeping on the streets is not necessarily related just to their own decisions, good or bad, but more related to structures, and that our society allows for some people to not be housed. And what do we do with that? Do we all own a piece of that collectively? Another one is moving from a standpoint of asking, say, a potential patient, what is wrong with you, to asking the question, what happened to you? And an example of this that I like to use is we have one of our homeless patients. We exclusively serve individuals experiencing homelessness at our clinic on Fridays. And this particular young man was sleeping on the street every night in the middle of winter. And it was, I mean, it's not as cold as it is up here, but it still gets pretty cold in Atlanta. And so he would often walk in and be very volatile in the lobby, often yelling or just getting highly agitated. Once he threatened to throw a water bottle at Brianna. And as the administrative officer, you know, I'm thinking like, I got to control the situation. Like, do I need to call the police? Do we need to add a security guard? You know, I'm starting to click through these questions of like, what is wrong with this gentleman? And can we even keep him in the program? And as I've worked with Brianna and really learned from her, I started to ask the second question of, well, what's happening with this guy? I mean, he's sleeping outside, it's freezing, he's coming in the morning and his hands are literally cracked and bleeding from being outside in the elements. Part of our care for him in the exam room usually involved doctoring his hands, and he doesn't have, you know, a support network, and, you know, just starting to put myself in his place and think, I might be agitated as well and throwing things if that was my daily reality. So if we start to ask that question of what's happening rather than what's wrong, again, it shifts the way that we think about these patients that are coming to us for care. And I will say, in a very positive outcome with this particular gentleman, we continued to work with him, developed a treatment plan. We tried some things didn't work. We tried again, and he's now housed and completely transformed. And we have not had any kind of an issue related to behavior. And I think it's because he now has what we all need, which is safe, secure, stable housing and effective health care. So that one I think is just really, really important, particularly for those of us who are actually in clinical practice. And then the last one, as we've already spoken to, is going from this idea of equality-focused solutions to equity, which from a patient standpoint is really just about building treatment plans that are highly tailored and personalized to each individual patient's need. And digging into this idea of narrative just a little bit more, as we continue to learn and grow at Good Samaritan, we've actually added a certified peer specialist to our team. This young woman, Marcia, she actually started in our homeless program, is housed, and she's now on our staff as a CPS. And it's been really fascinating to see her work and the power not only of her own narrative to transform, but the way that she pulls stories out of other peer patients that are experiencing many of the things that she once experienced and helps them transform that narrative into a position of strength. Marcia, who's quoted here at the top, has read our book, and what she loved about it was she felt like it really gave her a language, as I feel like it very much has done for me too in my own story, to describe what happened to her and also then to understand what's needed to recover. And Marcia also happens to be an excellent writer, and we're working on a chapter of a book for the CDC in which she's listed as the second author because her narrative and her story is included, written by her, in the chapter. And so we continue to look for more and more ways to use patients' narratives in the process of healing. And this can be done not only with CPS, but certified peer specialists, but also with providers, of even trainings for providers around how do you talk with and help your patients turn their narrative, which may feel like just a trauma narrative, into something that can be healing. I think there's a lot there. But of course, we cannot do it alone. We don't have as much time to go into the amazing work that the Good Samaritan Health Center does, but I'll just share quickly that we offer medical care, dental, counseling, psychiatry. We have an urban farm. We grow produce. We have a farmer's market, a fitness center, a host of health education programs, a teaching kitchen. It's a dispensary, which is about to become a pharmacy. I actually lose track of how many things we do now because there's so many, but it's truly a one-stop shop. But even with all of those great resources at our disposal, it's still not enough for all of the things that our patients need. So we still continue to push ourselves to think about cross-sector collaboration. So who are the churches? Who are the lawyers? Where are the child care facilities? So that when our patients have a need, we can point them in the right direction. I will just, as an aside, make a comment here that this is where, particularly working with boards and, staying in your lane and all that, it can get really muddy as to, okay, well, what is our lane if we're in healthcare and we have this farm? So what our board has done in terms of really identifying where we live and then where we collaborate is we literally just took 2 big pieces of white poster board paper and we made a list of what does Good Sam do well and what do we not do but our patients need. And then we just got real clear about here's our lane and here's where we need cross-sector collaboration. And then we just put names of organizations next to the partnerships needed so that we could fill in those gaps. And that's been really helpful for us as we continue to push the boundaries with our board as to what constitutes quality health care, because it really is a wide variety of things that impact people's health. And then thinking about advocacy, we've already talked a good bit about narrative and how we look inward for that. I think another piece of that that's important and is a step 2 after doing some of that internal work is thinking about health in all policies. So how are we engaged at the neighborhood, community level, state level, and even the national level on thinking about what policies either promote or detract from health for all citizens? And what might that look like to think about being part of dismantling policies that don't promote health for those in our community or those that we're serving through our clinics? But I will say one question we get a lot is, particularly when we talk about equity-focused solutions, is, the number crunchers in the audience are often thinking, this sounds expensive. How do you sustain this? And I heard a great quote recently, which is, reality has a way of pressure testing our best ideas. I mean, it does. In reality, this is, I don't want to make it sound, too optimistic. This is hard work and it's expensive work. And so when I think about sustaining this in the real world is, yes, it is expensive. It takes significant funding. The money's out there, but it takes going out and finding it, getting people excited about this mission of making healthier neighborhoods. It's just beginning somewhere. There's a lot. I think it's easy to get overwhelmed because there's so many things that are broken that need fixing, but just let's begin where we can with the patient in front of us. In terms of affording it, I do think that there are some creative options to look at. That is another presentation, but just more partnerships and working with people that are passionate about this work, and then being able to sustain it through much of it through this cross-sector collaboration so that we're not all reinventing the wheel, but we're leaning on each other's resources for the benefit of the patients that we serve. If you're really interested in this, there's a great article that actually will just affirm really all of the work that Americares is doing. HBR, our Harvard Business Review article called Transforming Healthcare from the Ground Up, that really just talks in particular about telehealth and the expansion of that, being able to double down on primary care, and then doing a lot more of this like health education classes and coaching, not necessarily kind of more on the preventative end of trying to keep people out of the exam rooms and educating them on the front end to avoid getting diabetes or hypertension, and kind of working with the education side even further. And then I'll just end with this quote that Dr. Elizabeth Boswell, a dear psychiatrist in Atlanta who actually with Brianna started our Friday homeless clinic program. I was sitting with her and asking, how do we do this? How do we sustain it? Asking her all those real world questions. And I was so struck by her answer, which was just, we can't afford not to. So I'll leave it with that. And thank you so much for your attention.
Looks like technology's not on my side today. Let me see if I can do one more thing here. Okay, 1 minute. Aha, there we go. Can you all see? Okay, perfect. Well, thank you, Brianna and Veronica, so much for traveling all the way from Atlanta to be here with us today and for your poignant and powerful talk. I think it is all so relevant and so timely. And it really, we're thankful to leaders like you who inspire us to start to think about how we can change our own narratives, but also pursue a culture of equity in the work that we do. So what you spoke about today really ties directly into the work that we're doing at Americares under the Roadmap to Health Equity. And it really is all about strengthening or doubling down, as you said, on primary care. And I think what you talked about in terms of the work of thinking about health equity and how do we start to begin to work upstream is really the vision for where we want to be able to go with Roadmap. So what we're aiming to do with the Roadmap to Health Equity is really focusing on the quality and equity of care, specifically delivered by a very important but often underestimated and sometimes overlooked component of our country's safety net, and that is the free and charitable clinic sector. And so with the last few minutes that we have together today, I'm going to talk a little bit about the Roadmap to Health Equity initiative. Because we have such a varied audience, though, I wanted to start by talking a little bit about who free and charitable clinics are, just to set the stage. So free and charitable clinics are healthcare organizations that provide a range of healthcare services, and you heard about some of the services provided by Good Sam, including primary care, behavioral health, oral health care, and lots of free clinics are now also offering services that start to address some of those social determinants of health. They do that all at no cost or for a nominal fee for their patients, but all and always regardless of the patient's ability to pay for those services. They serve people who are low income and who are either uninsured or underinsured, so folks who are traditionally considered economically disadvantaged. And one example of a group of people who might be served by free and charitable clinics are people who we might call the working poor. So those are people who are working, so they might not qualify for Medicaid because of their income, but they also can't afford to purchase their own health insurance, or they can't afford the high deductibles or co-pays for the plans that they do have. And so these are people who might otherwise fall through the cracks or end up relying on the hospital for their primary care, basically driving up costs to the entire system. So free and charitable clinics help to start to fill those gaps, and they essentially serve as the safety net to the safety net. So in order to carry out their operations, they use a combination of volunteers and paid staff to help them care for their patients. There are some exceptions, but very generally speaking, free and charitable clinics receive little to no federal or state funding, nor do they typically bill Medicaid or Medicare or private insurers for their services. And what we know is that the free and charitable clinic sector is dynamic and robust. There are close to 1,400 free clinics across the country that serve more than 2 million patients. They provide over 4 million services a year, and also have about 8 million volunteer hours that are donated to free and charitable clinics over the course of a year. There is also a lot that we know about the quality of care provided by free and charitable clinics from our long history as serving as a partner to the sector. So we know about the breadth of the sector and really the shift that's occurring now to start to think about quality through the information that's collected by Dr. Julie Darnell. She's one of the co-collaborators on the Roadmap to Health Equity and really the leading researcher of the sector. And she does a national census on the sector each year, so we have a lot of information and data about them through her work. We also know through the momentum we're starting to see from the National Association of Free and Charitable Clinics that are starting to move toward national standards for the sector, and also through some of the work that the state associations are doing to start to really push their clinics that are in their state to look at the quality of care that they provide to their patients. We also know from our work with many of the individual clinics throughout the country that a lot of clinics are looking at their own quality. They are looking at their own data on outcomes and if their patients are getting better through some of the programs that we offer that focus on quality, like the PCMH program. And so there are definitely ways that we know free and charitable clinics provide high quality healthcare. The question is, can we demonstrate it? Can we show that free and charitable clinics provide consistent quality care nationally across the sector? Can we answer questions like, are patients served by free and charitable clinics across the country receiving the care that they need? Are they getting better? Are people getting healthier? And does the quality of care at free and charitable clinics, how does it compare to other safety net providers like federally qualified health centers? And the answer to these questions is really the impetus for why we are embarking on this national movement and why the Roadmap to Health Equity is so critically important. Because there is no mechanism in place to be able to demonstrate or really evaluate the quality of care that's provided by the 1,400 free clinics across the country, which means that we lack the evidence to back up what we know. This really stands in very stark contrast to federally qualified health centers who are required to report data on the quality of care that they provide. And it really helps them, the data, to gauge their quality on a clinic level, but also allows them to benchmark their performance against their peers and on a national level as well. So we believe that having information and data is essential to sort of starting us out on this path to equity, and also to being able to make informed decisions about the quality of care. So to quote the great Peter Drucker, if you can't measure it, you can't improve it. And we're not embarking on this initiative or collecting information and data from free clinics for the sake of collecting data, but really for the purpose of improving quality. So together with our partners, we want to build on the work of the NAFC and individual free clinics and the state associations to develop an infrastructure to help us get there. Okay, so you might be asking yourself, and if you're not, I'm going to ask me for you, if we're talking about measuring the quality of care, then why is this initiative called the Roadmap to Health Equity? Well, let's look at the link between quality and equity. We heard a little bit about this from Brianna and Veronica, but there is an intrinsic link between quality and equity. And in the words of the Institute for Healthcare Improvement, which is my quality improvement muse, you cannot have quality without equity. So quality healthcare is really defined as doing the right thing for the right patient at the right time in the right way to achieve the best possible results. So an example of looking at a measure of quality might be looking at something like breast cancer screening or offering a mammography to women who are over the age of 45. Now, these are national statistics taken from the American Cancer Society, but in the way of just providing a simple example, you can see the data and the percentage of women who are receiving a mammography over the years is increasing. So over 2013 and 15, the data remains consistent at 69%, and then in 2018 it improved to 73%. So it's trending upward in a positive direction. This is just one example of a quality measure that a health center might look at. We're going to come back to that. So to further define quality care, there are 6 different pillars of quality care. Care that is safe, that's effective, that's efficient, patient-centered, timely, and care that is equitable. So equity has traditionally been considered one component of quality care. But I think what we're starting to see is that experts have started to shift their thinking to reflect that equity is not just one pillar of quality, but it's actually a cross-cutting component of quality. So what that means is that each component of quality healthcare, the care that's safe, effective, patient-centered, it means different things to different people, and you must consider those differences in your care delivery. And we heard a little bit about that from Brianna and Veronica, talking about how you start to address what individual patients need to make sure they can reach that apple of good health. So in looking at the definition of equitable care, again, this is sort of a little bit of a review, but it's care that doesn't vary in quality because of someone's race, gender, income, location, or any other aspect of diversity. But it's care that varies in practice because, again, it means quality care means different things to different people. So in other words, equity does not mean treating each patient exactly the same. Instead, it means moving toward optimal outcomes for all of your patients and understanding that different populations of patients may need different interventions or supports in order for them to achieve what they're wanting to achieve in their own healthcare. We know that members of racial and ethnic minorities, people of low income, the uninsured, the medically and socially vulnerable, the very patients that are served by free and charitable clinics are at greater risk for disparities in care. Let's stick with our breast cancer screening example, and let's look at this through an equity lens. So we looked at the data before for breast cancer screening rates. But what happens when we apply and look at this from different racial and ethnic groups? We can see that the screening rates for breast cancer screening are still trending upward, but women who are Hispanic or American Indian or Alaskan Native women are at much lower rates of getting a mammography as part of their health care. And so this can kind of shed a light onto where some of those disparities exist, so we can begin to think about how we design interventions to help us make an impact in those numbers. What's more, and this to me was really striking when we're talking about disparities, is that if you look at breast cancer screening rates for people who are insured versus those who are uninsured, I think these numbers are quite striking in terms of the percentages. And so again, just using information and data to highlight where gaps in care exist so we can begin to start doing something about it. So with all of that as the backdrop, let me talk a little bit about the goal for the roadmap to health equity. So the long-term vision or goal is not to collect data, but it is really to improve the quality of care and reduce health inequities for patients who are served by free and charitable clinics. But in order to get there, we have to lay the groundwork. And so how are we going to do that? Well, we have to start at the basics. And the first is really laying the foundation for beginning to collect information or data in a standardized way from free clinics. So if you think back to the chart that you guys showed at the very beginning, that circle chart where health was in the middle, and though only impacting 10 to 15%, it's like we have to start in the very middle with collecting information and understanding where we are so we can start to work our way outward and really impact the change. So what are we going to measure? What are we going to look at? We've identified 15 quality measures as part of the information we're going to ask free clinics to report on. 2 are that are required and 13 others that are part of a menu that really range from high blood pressure to diabetes to preventive care screenings like depression screening to behavioral health like unhealthy alcohol use. And we also identified that we need to be able to collect information about race, ethnicity, age, gender, and language so we can apply that equity lens to the data that we do collect to understand where we are with regard to the quality and equity of care we're providing. The second step really in the framework for achieving our goal is to have a way to report that information, have a way to report the data. And so it's to build the system, which we are doing through a partnership with Vision Tree. They are helping us build out what we're calling our repository to be able to start to collect this information from free clinics around the country. But we also needed to secure buy-in. And so we had to ensure that there would really be an adequate appetite for free clinics across the country to participate in this kind of work. And we, through an application process, secured what our goal was to get 50 clinics to participate in the pilot across 23 states. And so that's where we are now. The third step in the framework is to start to collect and then evaluate that data. And so once the system is built, which is currently underway, we're going to start collecting information from the pilot clinics who will report their information into the system. The data can be summarized then in dashboard reports, either at the clinic level, the state level, or the national level, to help us get a picture of what that looks like, to help us identify gaps and also to begin to diagnose disparities in care. And then finally, we will start using that data and dashboards and tapping into the expertise both within and potentially also outside of the sector to start to employ strategies and interventions around quality improvement and reducing disparities in care, to start to think about some of the strategies that Brianna and Veronica talked about today, thinking about things like education and training and engaging communities and cross-sector collaboration and all of these pieces that we can then bring together to start to impact that change and work toward our goal of improving the quality. So I talked a little bit about this, but I wanted to highlight a couple of the key milestones that we've hit along the way that we're particularly proud of. We've been at this work since 2017, which is where we launched the initiative. And I think one of the first things I just wanted to highlight is really the sheer number of people and stakeholders that have been involved in this initiative since we've started. We've had over 140 stakeholders, from executive directors to medical staff to state associations to EMR vendors, that are participating in this initiative and really contributing to how we move it forward and how we live into that vision that we have. We also have an established committee structure that meets on a monthly basis to really keep the work moving forward. In 2018, we were awarded a grant from the NIH, which is the first grant ever for the free and charitable clinic sector, to hold our first convening, and that's where we came to consensus on what we were going to ask free and charitable clinics to report on. We also worked really hard over the course of that year to come up with our value proposition and why this work is so important. And I just wanted to highlight this quote from a clinic leader who shared this with us, and particularly that last one that I think really describes it best about why this work is so important and how and why it matters to have the data to back up outrageous claims that poor people are disposable or undeserving of help. And so, I think that we're starting to change our own narrative by looking at how we think about these things and why this is important for the sector. In 2019 was really the turning point where we started to really live into the work, and it started to come together where we engaged with that vendor vision tree to really make it start to happen, and where we also confirmed the pilot clinics, and we held our second convening in Atlanta to set the stage for 2020. And we're really excited. Oh, this is a picture of us at the convening and all together. And we're really excited for this year because this is where we'll begin the data reporting from the pilot clinics, but we're also laying the groundwork for future work we want to be able to do through Roadmap, and that involves also measuring and looking at the social determinants of health that are impacting our patients. So that way, when we continue to move forward, we have the information that we need to continue to make an impact. So there's a lot of different ways that you can get in touch with us. If you have any questions or would like more information, we have information on our website and also on the NAFC website. But I just wanted to leave with this quote today because we know disparities in care exist. But this comes from Dr. Dawn Berwick at the IHI, who's one of my heroes, that we cannot achieve health and accept vast inequity because that is a bankrupt idea. The causes of causes are not ours to accept, they're ours to change. And that's what we're working to do. So thank you.
Thank you, Christina. Thank you to our guests. We'll conclude now. We do have a question and answer period, though. If anybody does have questions and want to come back up, Brianna and Veronica.
We're happy to take any questions or just experiences or thoughts you have.
You two go around and you speak to a lot of groups in your area and talk about your work and things like that, but when you connect that to the roadmap to health equity, do you see the fact that you can collect this information and collect this data? Does it help you with your fundraising? Does it help you with explaining to people the needs and why and actually backing it up with the data? Do you use it in that manner?
Sure, absolutely. So the question is about with connecting to the roadmap project and being able to have more access to data, is that something we would use in our fundraising? And I would say absolutely. We already use our own data heavily in fundraising, as well as data that Donna Looper with the Georgia Charitable Care Network has compiled for the state of Georgia. I will say most of our current funders are local to the Atlanta metro area and maybe just outside. But if we had that larger scale data and could talk meaningfully about how we are a piece of that puzzle, then I think we could go after some outside funding, which we're kind of limited at this time because most of our information is more local. But yes, absolutely, we will use it.
I'll also just add that I think, as Christina mentioned, it just helps for the general conversation with anyone we're touring, funders or visitors, that it makes a difference to invest here. We talk, for example, we talk about that our homeless outreach program, 70% of patients follow up. And I think it just helps to dispel ideas, as your quote perfectly illustrated, this ideas about that, well, is this a good place to invest money? Will we see better health outcomes? Will patients take advantage of services? And overwhelmingly, I think for me personally, years of this work just continues to tell me yes. And so having data like this also just tells that piece of the story, to say that our patients take advantage of all of it and they get healthier. So let's do more of it and do it better.
Yes, in the back.
Hi, the social determinants of health story is a really positive story, but it seems like it would benefit even financially at a more global level, supporting it more legislatively and selling that story in that way, because we have a lot of people who are living an old narrative. And if we switch the narrative, we could probably solve some of the financial problems that we have with healthcare. Where are you intervening legislatively, and what other opportunities are there to get involved?
So a couple answers to that. On the Good Sam side of what we do, we are a non-political organization. We definitely engage in local level conversations. For example, with the Georgia Free and Charitable Care Network, we advocate for policies that help keep clinics like ours open. But my hope is that as we talk, that we often talk to folks where there aren't healthcare people in the room, and a lot of what we talk about is identify the policy within the sphere where you work and live. And the way I like to think about it is often when we hear policy, we think right away like elections and parties, but policy is happening from very local decisions on school boards and on zoning issues to these big legislative monsters like Medicare and Medicaid processes, and actually decisions that are made on that entire continuum have the ability to impact health. For example, I think one eye-opener to me was as part of the second part of our book, we interviewed just national leaders who have done really exciting things locally to address social determinants of health. And I went into healthcare knowing nothing about housing and found that I really needed to understand housing as a social determinant, and someone that was very helpful for me was Cole Thaler, who talks about that, what if citizens said, we're not letting you build in our community without certain percentages allocated for affordable. And not only that, we want to help define what is affordable for this community. And could that be applied not only to rental units, but to purchasing units? And those types of community action, even at a local level, could be just like life-changing for the number of families that would have access to affordable housing, especially in our urban areas, Atlanta being one that's growing rapidly. Another example would be like at a set, kind of a larger level is state-based policy around Medicaid. Like going and telling our stories of, if I had patients coming in my office that all had Medicaid, what would I use my time that I spend trying to connect them to specialists and beg, borrow, and steal to put together treatment plans? Where would I use that capital and resources and time as well as fundraised money? What more could we do if we were setting a minimum of insuring everyone? So I think that's your point is perfect, is that we not only look at our personal narratives, but then we say, well, what's the narrative around this policy? What are the stories playing in, and can I share part of my personal experience or what I've unlearned or learned from my work in the free and charitable care world to help inform this process and encourage colleagues and friends and family to also engage in saying that it's these day-to-day big P, little p policy decisions that have huge impacts long-term on the health of our communities, as well as the cost savings or lack of thereof if we don't start implementing changes.
Yes.
You mentioned the need to be introspective about our own relationship with inequity and oppression. How do you suggest that organizations, whether it's clinics, organizations like Americares, or even some of our donors, begin having those conversations?
That's a great. I can start.
Yeah, go for it.
I'll be totally transparent and say that, for me, a lot of that work, I actually did implicit bias testing. I've done it a few times, and they're eye-opening results. And I wasn't pleased with what I saw the first time, and it rocked my psyche as a college student was the first time I did that testing. And I think for me, it was having just a better understanding that implicit bias is around all issues, race, poverty. There's testings on even weight in the workplace, drug use, for example. But on all of these issues, we carry stories that we were told and raised with. And so I think sometimes just sharing resources to say, can we do testing? And then also there's a lot of experts that do teaching on equity, diversity, and inclusion training that have really, their entire organization focuses on how to unpack those issues. So I think being introspective personally and saying there's resources that I can go test myself, but then saying, can we make that available to my organization? Can we use staff meeting time to have trainings to open our eyes to this? And then I think third is I would also say to be committed to the long run, because you don't change implicit bias overnight. And it takes experience and time. There's arguments that implicit bias isn't as much changed as it is you learn to act differently than your inherited biases. And it's that learning that takes place over time. And as we know, if anything else, learning doesn't happen overnight. So saying, having a one-day diversity seminar doesn't make us an inclusive organization. So let's admit that and then say, okay, so what's next? What did this uncover that we unpack next time? And what does this mean? And then last, I guess that wasn't my last one, sorry. The last thing I would also say is making sure that there's spaces for voices of people that have often been oppressed in corporate and organizational settings, whether that be sexual identity, gender, race, mental health, illness, to say where are the spaces to hear their stories? Because I've found, at least in sharing, is that what often changes folks' ideas around these topics is the stories. And we use our story of our own kind of shortcomings and learnings, but we also, throughout our book, we're able to use stories of patient experiences and just saying this situation was easy to judge until you knew the whole story. And so where do we create spaces in our own lives to hear stories from people with different lived experience, and then where are we using the platforms we have to amplify voices of people with experiences that might differ from our own?
And I'll just add on the donor side, because I do think it's hard to talk about narrative with a donor over breakfast or lunch, and probably not the right setting in which to do that, and because you're there to really sell or promote your organization. That's one way that I actually use our book a lot, and we give away a lot of free copies of it to potential donors, because it does have not only our story of transformation, but there's a lot of patient stories in it that as you read the book, you can kind of learn without being directly told that there are these factors that are different than what those of us who, like myself, who grew up middle class might think, that are impacting these people's lives and outcomes. So I would say if you have someone that is a potential donor that will hang with you and put in that kind of time, that you could share a copy of our book or a similar book. We love Just Mercy is another great one that can get, sheds a different view on what people have thought of in that case with the criminal justice system. But depending on where the donor's coming from, maybe sharing a book and then having a follow-up conversation. I have one donor for Good Sam that I literally have lunch with quarterly, and now it's much less about making an ask and just, what are you learning? What are you reading? And talking about those topics, but it's much more suggestive than direct related to the narrative piece. Yeah. Yes.
So you've appropriately painted such a beautifully broad definition of health that we don't often find in our own healthcare system. The little social determinants are really boiled out and we just get down to sort of health technology. That's what we really deal with most of the time. You're in an advantage in some sense being a philanthropic organization, because as long as you have a supportive board and you have donors, you're able to broaden the areas of health broadly defined that you can work in. The rest of the health system is constrained by a payment system that's for procedures and treatments and things like that. Any thoughts about how we take this whole idea of social determinants and move it into a sector that's just driven financially by a completely different model?
I'll just share one thing just to.
Maybe just repeat it.
Oh, yes.
Briefly.
Yes. So how do we, in terms of social determinants, really move this conversation from being just with clinics and nonprofits that have a little bit more ability to be flexible and address some of these things, but actually move it into the larger healthcare system that is very much constrained by the way the system is set up? Brianna will have a better systems answer to that, but I just wanted to, in solidarity, say that we actually do run up against limitations with it, but it's not necessarily with our board, although sometimes even we push them a little bit too far. But we're just going to keep doing that because that's how you innovate. But we run up to it actually with funders, going back to that question where we were working on and we're still working on it, but we've had to adjust a little bit. We were working on this really interesting collaboration with a permanent, supportive, and affordable housing developer that we wanted to work together to buy this piece of property next to our clinic, and then they were going to build the housing, and then our homeless patients were going to live there, and then we were going to be their doctor, and it was going to be awesome, and we were just like already there having the ribbon cutting, and we went to one of our most faithful foundation funders. Our founder is friends with the president. I mean, it was like it could have been an easy yes, and basically their response was housing is not healthcare. And it from a development person standpoint, I realized I needed to do a little bit more of that context building for the funder, which we're now doing on the back end. But it was just this eye opener to me of like the funding community isn't necessarily there yet to see housing as healthcare, even though Kaiser and all these other groups are putting out stats and articles showing that yes, it very much is a healthcare issue. But we have to, that kind of keeps us in check on our side, even though you're right, if you can find people to fund it, you can do it. But I think the challenge is even finding people to fund it because it is a very new idea to address social determinants.
I'll add one quick thought. We were invited actually by a major private insurer to join their panel and speak. And at first, my initial reaction was, do you know, have you heard us speak? But I was actually, I did the panel and joined them, and I was actually really excited because I do think even private insurers are starting to say, we are spending a lot of money on things that might have been cheaper to fix before they were here. I think that's a game changer, is that the more that health execs and the private industry also sees this as an issue, as well as like Medicaid being a major funder, Medicare, as they start to see the value in this, then they will start to reimburse for the time that it takes a provider to do this well or to hire case management. We had one moment I'll never forget on our, we were recipients at Good Samaritan of Americares assisting us in doing the patient-centered medical home process. And when we were on our check review on the phone with the reviewer, we had checked in our social determinants of health screen, and he had been just clicking through things, and he said, okay, I guess got to pause a moment and just pull out the guidelines on this one, because I don't have many clinics ever check this one in. And it was super eye-opening for me, because there aren't a lot of free and charitable care clinics going through the PCMH process, which meant to me that most of these private clinics aren't screening for social determinants of health. I think they're being pushed to because of the data. And so I think that goes back to the more data we have on understanding social determinants and their importance, the more we push those big players. And then I think the second piece, too, is to just change the conversation from saying social determinants is a healthcare conversation to saying social determinants is also a transportation conversation, and it's a housing conversation, and it's a food access conversation. That if we have colleagues that are spending their days in food advocacy or in affordable housing advocacy, if they are saying the same narrative, like at the end of the day, if we want a sustainable economy where people can live to life expectancy, this is what we have to do, then those systems start to collide, and we start to have this unified goal that transcends just the healthcare system, but unites a lot of these systems and and each of the strengths and the resources we bring to the table. You were?
Yeah, I was just going to add a question to that question, which is, while we're collecting the data, there are stories out there, it sounds like, not only clinics, but communities that are doing things really well. They're doing things better than most to narrow that gap. So how do we find those stories of communities who are doing it right, so that we can influence and advocate and fundraise?
That's a great question.
So the question is, how do we find more of the stories of how communities are doing this right in terms of addressing social determinants? And I'll say I hear most of the stories outside of the ones we know through our own work at these free and charitable clinic state association meetings. I was recently in December in Florida with their annual state conference, and I heard just amazing stories of what a clinic serving in kind of like a quarterback role for a community. If you think about like the purpose-built model, the clinic had kind of stood up and said, hey, this is an issue we're going to lead out, but we need, partners around us, and just really neat stories of things that were happening at the very, very small, local, even rural level. So I would just encourage, if you don't already, folks to attend those conferences, or maybe get in touch with the executive directors, which we can connect you with some of them, because I think a lot of those stories do live at the clinic level. I think, unfortunately, because most of us are just caught in the day-to-day of just trying to run a clinic, it's hard for us to push those stories out. But they're there for sure. That's the good news. The stories are there. It's just mining them out and then amplifying them. Yes?
So when I think about this topic, I think who benefits the most will be the ones that change first, but they need the data, so I applaud the data collection. But state governments would benefit the most. So engaging states. So for example, the shift that occurred in Maine with the governor has opened an opportunity. So I have friends that are trying to work on this right now in Maine. Same
awesome.
thing's happening in Denver. In fact, they just hired someone who's trying to pull this together. And I'm wondering how we can be learning from each other across those states where they are experimenting more holistically and systemically, as opposed to from a grassroots level. Because the clinics, like you said, you're kind of in the mire of it. If we can start building that value proposition at the state level and then start partnering.
Right.
It's always been like a little bit of a passion to get us thinking more holistically.
Yeah.
So do you operate or connect around the country, not at the clinical level, but kind of state level?
Not as a clinic. There is the National Free and Charitable Care Association, and so when we come together for that conference, and it's kind of a small world, we always joke that we show up to various things and we're like, Wait, I saw you last month. So I think that in terms of national around the free and charitable clinic world is where people are colliding. I think there is still a little more focused conversation on like the actual clinics and their sustainability, not as much on state level policy. I do think that where a lot of avenues are for that are that there are a lot of healthcare organizations that have much more of a policy and advocacy focus. So if you look at like your nursing associations, some of these like more professional associations actually most of their time is spent in that type of advocacy. I think the tricky part is that, healthcare is difficult. It's difficult to survive not only in the free and charitable care world, but just in private practice. Burnout is high. We're paying a lot for healthcare. It's not a very popular industry right now. And so a lot of time is being spent on these smaller level policies to just survive. And those take precedence under really arguing for these more systemic level changes. So I think there's a lot that could still be tapped into in terms of saying, okay, where are some easy centralizing places that we can have those conversations. Where I often find them the most is social media. That, people that are passionate about this find their connections, and it's this organic sharing of what we're doing and what's going right. And I think that can be social media can be used for social change. And then I think the other way, I know for me, how I find out like what's happening is Maine is that someone publishes. Someone says, this is what we did to advocate, or they say, this is what changed and this is what happened in my clinic because of that change. And so just encouraging people that it is hard to see patients all day and do anything else, or to like keep the budget so the clinic can stay open all day and have any energy left. But can we create spaces in our organizations and empower clinics to have time not only to collect the data, but then to reflect on that data in light of their state's situation, so that we can start pulling those connections to say, okay, if clinics in Georgia are experiencing this, are there similar barriers? And then saying, okay, well, that's a case to go to the state and say, we would just like to show you that you've got all these different clinics serving some of your highest risk ER utilizers, highest costs, vulnerable constituents, and all these clinics are experiencing this barrier in common. So let's start having a conversation around what do we do from a policy level to address that barrier.
I will also just share that the Georgia Charitable Care Network and probably other networks do it as well, but we do an annual legislative dinner where our state legislators come and we share with them about the clinics, and then we have a lobbyist that the network pays to lobby on behalf of specific policies that would impact the charitable care network sector. I will say the challenge with it is with this once a year dinner, it's really hard to have, because I'm usually there as a board member, it's really hard to have a meaningful conversation. And in terms of the narrative piece, at least maybe this is just Georgia, but the narrative is so far behind what we're talking about today that it's hard over dinner to like unpack so many things that would have to be unpacked to even have a meaningful conversation. So that's a challenge that I feel. And then we don't get FaceTime beyond that with these folks other than that once a year. And then even that, it's like pulling teeth to get them to show up to that dinner. And then in terms of the paid lobbyists, her work is really focused on very granular level policy, like about the issue with could a hygienist be operating in the dental office without the dentist on site? And, that was a big thing one year. So I think that just some of the challenge is how do we get into the room with these folks that are setting policy and let them hear some of these stories, because I think we have, these echo chambers where we're all telling these stories and we're all probably in agreement that this is an issue, and then they're in a separate world. And there's a huge disconnect on the understanding of social determinants, at least for the folks I've interacted with. So I think there's another opportunity there, and it seems like when their ears perk up, this is going to sound cynical, but I'm just sharing my experience, their ears perk up when it can tie to votes or it can tie to dollars. And so we need to have data that says if you address social determinants of health, this is the number of billions of dollars that your city can save to reinvest into other projects. Then the conversation will start going somewhere. I'm not aware that that data exists yet, but that would be maybe the next step of how do we model that data so that we can actually have some real leverage in these conversations.
Yeah, I was going to ask about that, because to me, the social impact bonds, where you can actually show that the data has saved
Yeah.
millions, or in each state, but then maybe billions across the entire country.
Yeah.
You can't do that until you have the data.
Right.
And I'm just curious if you have looked at social impact bonds that you've seen, at least either being talked about or already in the marketplace, that are doing what you think could be done once we have this data.
I have not personally.
Yeah, I think one avenue that I think has a lot of strong research now is in the health housing collaboration. I certainly don't want to say I'm an expert there, but they have great numbers. And when we were working on kind of those chapters of the book, the research was really plentiful compared to other avenues. There's been really kind of gold standard models that have been tested and piloted on how do we approach homelessness. The Housing First model, for example, went to a random controlled trial. That data is like liquid gold. I mean, it's at the level of like almost causation, like really being able to tie that closely. So I do think that's happening in some of the kind of collaborations where maybe it's an easier jump than maybe health to transportation, but there's always room to continue that data process. I will just add that I have still felt that there's a need for both the data collection and sharing, but also the continued work we do personally and in our own interactions with people around that idea of narrative. And I think, for example, being from Georgia and watching the conversation around Medicaid expansion, that there is not a lack of data on predictions of what would happen with Medicaid expansion. Like, it's not necessarily a data problem, but it's a philosophical discussion on what do we believe as a state on how we give out Medicaid. And I think that type of discussion only gets changed through the storytelling component, not just the data component. And not just me telling the story, but that person's, that maybe that legislator's niece tells him the story, and then he visits a clinic, and then he has dinner with this person, and that repeated kind of challenge of that narrative to say, okay, maybe I should reframe how I was thinking about that, because the data is sitting right there. So I do think there's need for the data, and then there's the need for the storytelling, because both have to be in place to really change policy.
These are great questions.
Yeah, I love these questions.
Okay.
I think we're at time.
Sure.
So just thank you again, and everybody, please just thank Brianna.
Thank you. This is great. Thank you so much.
And we'll be around if you'll have other
We're
questions.
going to have light refreshments and just a reception in the lobby, and hope everybody can join us there. Thank you so much.
Thank you.